Hello and welcome. My name is Yenmi and I like to talk about all things medications related. Over the next couple of videos, I'll be talking about dyslipidemia, the medications used to treat it, and some of the treatment goals. So with that being said, let me just go ahead and begin. Before jumping into the medications and the treatment goals in dyslipidemia, let's start with a brief and oversimplified review of cholesterol, triglycerides, lipoproteins, and the development of atherosclerosis. Cholesterol is essential for regulating cell membrane structure and fluidity, and serves as a precursor for bile acids, steroid hormones such as glucocorticoids and sex hormones, as well as vitamin D. The liver produces all the cholesterol the body typically needs, but we also obtain it from dietary sources. It's important to remember cholesterol cannot be degraded by human cells, so either it gets excreted via the bile or converted to other molecules. If not, it begins to accumulate. Triglycerides are the major storage form of energy in the body and derived from diet or synthesized by the liver and secreted as VLDL. Excess calories are converted into triglycerides and stored in adipose tissues to be used as fuel at a later date. Triglycerides and cholesterol are lipids that do not dissolve well in water. Therefore, to travel through the bloodstream, they must be packaged into spherical particles called lipoproteins. All lipoproteins share the same basic structure: a hydrophobic core composed primarily of triglycerides and cholesterol esters, surrounded by a hydrophilic shell composed of phospholipids, free cholesterol, and apolipoproteins. Lipoproteins differ in their composition, size, density, and associated apolipoproteins. Five major classes of lipoproteins found in the blood are chylomicrons. These are the largest and least dense, composed of 98 to 99% of lipids in the form of triglycerides and only 1 to 2% of protein. VLDL, which stands for very low density lipoprotein, are about 90% lipid and 10% protein. IDL, which stands for intermediate density lipoprotein, is a transitional lipoprotein formed during the conversion of VLDL to LDL, but is still atherogenic. LDL, which stands for low density lipoprotein, is smaller, but is about 80% lipid, but in this case, it mostly consists of cholesterol esters instead of triglycerides, and 20% protein, mostly apolipoprotein B100. And finally, HDL, which is high density lipoprotein, which is the smallest and most dense, but is about 50% protein, mainly apolipoprotein A1. From chylomicrons to HDL, particle size generally decreases while density increases. This occurs because of metabolic remodeling of these lipoproteins in the circulation. As chylomicrons and VLDL circulate, the enzyme lipoprotein lipase hydrolyzes their triglyceride core, delivering fatty acids to tissues. This progressively shrinks the particle and removes low-density lipid, leaving behind a relatively protein and cholesterol-enriched remnant. IDL is further remodeled by hepatic lipase into LDL. Each class of lipoprotein has a specific role in lipid transport. Lipids are transported through two major pathways: the exogenous pathway and the endogenous pathway. In the exogenous pathway, dietary triglycerides and cholesterol are absorbed by intestinal cells and packaged into chylomicrons. Chylomicrons enter the lymphatic system and then travel through the bloodstream to muscle and adipose tissue. In the capillaries of these tissues, lipoprotein lipase hydrolyzes the triglycerides within chylomicrons, releasing free fatty acids and glycerol. The fatty acids can then be used by muscle for energy or stored in adipose tissue. Most of the glycerol returns to the liver. After losing most of their triglycerides, chylomicrons become cholesterol-rich chylomicron remnants. These remnants are taken up by the liver. The cholesterol can then be incorporated into cell membranes, stored as cholesterol esters, converted into bile acids, secreted directly into bile, or repackaged into liver-derived lipoproteins. In the endogenous pathway, the liver packages triglycerides and cholesterol into VLDL particles. VLDL transports these lipids from the liver to the muscle and adipose tissue. Lipoprotein lipase hydrolyzes the triglycerides within VLDL, releasing fatty acids for energy or storage. As VLDL loses triglycerides, it becomes IDL. IDL may then be taken up by the liver or undergo further remodeling to become cholesterol-rich LDL. LDL delivers cholesterol to peripheral tissues and the liver as well as the liver, and plays a major role in atherogenesis. Cells take up LDL via LDL receptors that recognize apolipoprotein B100. HDL, on the other hand, is assembled differently. Excess cholesterol is exported from macrophage foam cells in the arterial wall to extracellular HDL acceptors via three main routes. The most efficient of these pathways is via the ATP binding cassette transporter A1, which is responsible for over 50% of macrophage cholesterol efflux. It transfers free cholesterol and phospholipids to lipid-poor apolipoprotein A1. Reverse cholesterol transport is another important lipid transport pathway. HDL can be directly delivered to the liver or via an indirect pathway. In the indirect pathway, cholesterol ester transfer protein transfers cholesterol esters from HDL to ApoB containing lipoproteins such as VLDL and LDL in exchange for triglycerides. These particles can then be delivered to the liver. Once cholesterol reaches the liver, it can be secreted into bile as either free cholesterol or after conversion into bile acids. Higher HDL-C levels are generally associated with a lower atherosclerotic cardiovascular risk. Another important lipoprotein I have yet to mention is lipoprotein a, commonly referred to as Lp(a). Lp(a) is an LDL-like particle containing ApoB100 covalently bonded to apolipoprotein a. Levels of Lp(a) varies and are determined mostly by genetics. Observational studies and genetic evidence suggest that Lp(a) is pro-atherogenic, pro-inflammatory, and pro-thrombotic. Lp(a) resembles plasminogen and is believed to compete with plasminogen for its receptor on endothelial cells. This is believed to result in less plasmin being generated, which inhibits fibrinolysis, which promotes thrombosis. The pathophysiology of atherosclerosis is not completely understood and really quite complex, and I could probably spend another video or two just talking about it, but I'd rather focus my time on treatment goals and medications. So I'm just going to summarize this into 5 oversimplified stages. Atherosclerosis is a chronic inflammatory disease affecting the inner layer of medium and large arteries, characterized by the accumulation of ApoB-containing lipoproteins, inflammatory cells, and fibrous tissue. Stage 1, endothelial dysfunction and lipoprotein retention. Continued exposure to risk factors such as hypertension, diabetes, smoking, dyslipidemia, and disturbed blood flow leads to endothelial dysfunction. The damaged endothelial layers causes impaired vasodilation, increased permeability, and upregulation of adhesion molecules. Apolipoprotein B containing lipoproteins, mostly LDL, penetrate the endothelium and become trapped where they undergo oxidative and enzymatic modifications. Stage 2, foam cell formation. The oxidized LDL particles activate endothelial cells to express chemokines that recruit circulating monocytes. These monocytes migrate into the intima and differentiate into macrophages and engulf the oxidized LDL, becoming lipid-laden foam cells. Accumulation of foam cells produces the fatty streak, the earliest visible atherosclerotic lesion. Fatty streaks can begin developing as early as childhood. Stage 3, plaque growth and fibrous cap formation. Inflammatory signals stimulate vascular smooth muscle cells to migrate from the media into the intima, proliferating and producing extracellular matrix proteins such as collagen and elastin to form a fibrous cap that stabilizes the growing plaque and separates it from the circulating blood. In this stage, cytokines such as interleukin-1 beta and interleukin-6 are released from macrophages, adding to the cycle of immune cell recruitment and chronic inflammation. Stage 4, necrotic core development. As the plaque enlarges, foam cells and other cells undergo apoptosis and necrosis, which leads to the accumulation of cellular debris, extracellular cholesterol, and cholesterol crystals, forming a lipid-rich necrotic core. Stage 5, plaque complications, rupture, erosion, and thrombosis. Advanced plaques can produce acute cardiovascular events through either plaque rupture or plaque erosion. Advanced plaques may develop a thin fibrous cap overlying a large necrotic core. Cells such as leukocytes surrounding the plaque can release matrix metalloproteinases that degrade collagen, thinning the cap. Rupture or erosion of the fibrous cap exposes thrombogenic material to the bloodstream, triggering platelet activation and thrombus formation. The resulting thrombus can partially or completely obstruct an artery or embolize downstream, causing acute coronary syndromes and ischemic strokes. The last topic I'll touch on really quick are lipid panels. A standard lipid panel measures total cholesterol, HDL cholesterol, and triglycerides. It also shows a calculated LDL and a calculated non-HDL. Total cholesterol is cholesterol carried by all lipoprotein classes. LDL cholesterol is cholesterol carried within LDL particles and is calculated rather than directly measured. HDL cholesterol is cholesterol carried within HDL particles. Triglycerides are carried primarily by VLDL and chylomicrons. And non-HDL cholesterol is cholesterol carried by all atherogenic particles and is calculated by total cholesterol minus HDL cholesterol. Previously, we used to use the Friedewald equation to calculate LDL cholesterol. The 2026 ACC/AHA guidelines recommend either the Martin-Hopkins or Sampson-NIH equations over the traditional Friedewald equations. These provide greater accuracy across a wide range of LDL and triglycerol levels. And that was your dose for medication education. I do hope you learned something today and enjoyed my video. If you did, hit that subscribe button and comment down below. It would mean a lot to me. Thanks. Have a good day.